We should be paying attention to each unique day, what should happen, because this is not an accident. We're controlling the narrative. What are we saying? What are we doing? We're not just letting staff members say whatever they want. Because remember, there's this thing called present time consciousness. What you can and can't say to a patient relative to where they are in the relationship. What can I say about need relative? So what are the stages of the relationship with present time consciousness? New patient or a patient on the outside, you're trying to get them in. That's one. So there's very specific things I say and do, and there's damn well things I don't say. And 2, get them from day 1 to day 2. 3, from day 2, commit to the next 2 days, that day and the next 2 days. 4, day 4, commit for the 3 phases of healing. 5, lifestyle care. So how many present time consciousness do you have? New patient to get in, 1. In other words, I can only talk to them about need, time, and money relative to that window. I can't talk to them about maintenance care. Okay? That's called a paradigm shift. That's when you increase defenses and resistance and violate trust. Now, we'll go into that separately. I'm not going into it now, but you have to have a heightened awareness because chiropractors are notoriously bad at just talking about anything and everything, not even knowing that there's different stages in a relationship. You know, they'll talk about maintenance care and the patient hasn't even come in. Or they'll say they can help them. You know, how many times does that happen? You go, oh, yeah. Somebody goes, yeah, I've got this problem covered. Oh, yeah, we can help that. They just said the wrong thing. They just killed the potential. They didn't even know it. So get them in, need time or money, day 1 to day 2, day 2 to day 4, day 4 and 5. So you got about 5 different categories.
You're welcome.
And so when I'm doing staff meetings, one of the things that I'll do, just to kind of keep them on their toes and make sure they are aware, I'll say, okay, Cindy, let's say Cindy's the therapist. Okay, Cindy, what do you do on day 2? The patient's leaving and it's a workers' compensation patient. What do you say? Well, she should know the bullet points.
Right.
We do this, we do this, we do this.
Mm-hmm.
See how that works?
Yep. Personal injury.
That's, in other words, you should be able to go through all unique 10 visits and each station know exactly what to say and do when patients come to them and when they leave relative to present time consciousness, need, time, or money. Now, that will seriously increase the effectiveness and efficiency of patient flow. And then remember, you always have to have a central location where anybody can look, because what's the worst thing that you need to totally avoid is that during the industrial hours, especially during the industrial hours, one employee has to stop what they're doing, then to go to another person, another employee or the doctor to ask them something. That tells you you don't have a good trained staff. Now you stop 2 people from doing their job during industrial hours. Chaos. That's like a telltale sign. When I go into an office and I see that, that's just another telltale sign there's very bad training going on. Okay. So that's why there should be an area, whether it's, and again, it totally depends on how you do notes. There should be an area, whether it's paper or electronic or whatever, that each staff member can look at, and they should know the patient's schedule. They should be able to look at it and know if the patient's daily, 3 times a week, once a week, twice a week, they should be able to. And then it's the 80-20 rule. Remember, there's a rule for everything, but nothing goes 100%. But if everybody knows the rule, that's what everybody's trying to push toward. So the 80-20 rule for 3 times a week are Monday, Wednesday, Friday.
Mhm.
If it's twice a week, it's Monday, Wednesday. That's the rule. If it's once a week, it's Wednesday. So they look at it and they go, like in mine, I would put 3x. 3x means 3 times. And then I'd put 4 WK, 4 weeks. Well, they'd see 3x times 4 weeks, and they know the rule. Well, we're seeing them 3 times a week. So if today's Wednesday, they need to tell the patient what? We're going to see Friday.
We'll see it right.
I didn't have to stop. I didn't have to stop and ask anybody. See?
Right.
Okay. So I wanted that on the treatment schedule like that. And remember, they're always scheduled to the next re-exam,
Mhm.
not day to day.
Right.
And then I wanted money, especially what their cost per visit is. So typically I would write because it can vary. You get in the room and you could agree on something different. So I always have what the cost per visit is, and how the staff members knew that's what it was that I agreed with the patient as I circled it. So I may have put 40 and circled it. Well, they knew what that meant. That meant the cost for that patient, them personally, was $40. Okay. And then if they did prepay, I would put a check. Like whenever we had put the schedule down 3 times a week or whatever, twice a week, whatever, I put a check that way they knew the patient prepaid. So I want the visits, I want the cost, because remember, what matters to the patient? When are they coming in again? How many times does a patient get turned to the staff and goes, when's the doctor want to see me again? That's, again, when I hear that out of a patient, what does that tell me? The doctor's doing a terrible job of patient education. That's what it tells me. No patient should ever have to say that. And then the staff member go, well, I don't know, let me check. That's chaos. That should never happen. So all of these are clues. If these things aren't getting done, it just tells you a whole lot of other things aren't getting done. Okay. And remember, staff will take the easy way out. They won't think. You already know this. They'll put everything on you.
Mhm.
And so you can't do that. You got to hold them accountable so they can think, follow the rules. So that's what you need to be aware of. That's what Dylan, you need to be aware of is present time consciousness with need. Need means they're talking about their problem. Need, time. There's anything time relative. Money. Those are the big 3 topics you've got to be a black belt at every phase of the game, at every stage of the game. So and I may only do that a few after they're trained. I'll say, okay, front desk, I'll say, okay, Marilyn, what do you do on day 4? Workers' compensation patient, the patient's leaving. And she'll say, I do this, I do this, I do this, I do this. See? That's how I test them to see if they know what they should be saying and doing at each interaction with the patient. You get that down, you're going to have a really smooth office. When everybody doesn't have to talk to everybody, everybody knows the rules. So even if a patient doesn't fit into the rule, like say they can't come in Monday, Wednesday, Friday for whatever reason, they can come in Monday, Wednesday, Thursday. Well, the staff pushes for Monday, Wednesday, Friday, but before they cave, they knew how to introduce the 3 time obstacles.
Mhm.
They didn't just cave.
Mhm.
And then if they couldn't get it with the 3 time obstacles or personalize it, then and only then they went to Monday, Wednesday, Thursday.
Correct.
But they knew where to focus the attention, not just let things randomly happen.
Mhm.
Okay. So yeah, the patient's in a totally different relationship, whether you're trying to get them in, whether it's day 1, trying to get them to day 2. And again, those are major topics. We talk about this to exhaustion. And matter of fact, I touched on this yesterday a little bit, how important those 4 days are. Everything that happens You go, well, what are all the dynamics that happens? Why are 4 days so important? Well, that's the natural purchase cycle, number one. Number two, that's you have the highest amount of trust due to multiple contacts. Number three, you're answering their questions that they have in sequential order. What's my problem? Can you help? How much is it going to, how long does it take to get better? How much is it going to cost? So you got multiple factors of why it's 4 days, not two. And you're not violating natural principles of how we buy products and services. You're actually using them to the best. You're maximizing the opportunity by following those systems. Okay. So that's what needs, we got to be highly aware of that. That's what you should be. So now all these patients are, we know what to say, what to do for each of the visits. We know present time consciousness. And then we have to go into, you got to spend a lot of time on, we're not going to go in the need yet. We're going to go into money. Make sure that Dylan knows how to talk about money when the patient's on the outside and you're trying to get them in.
Okay.
That's called the offer.
Mm-hmm.
What do we say with time when the patient's on the outside and we try to get them in? And then you have to look at the 5 major financial categories. Okay, well, what if it's a PI? What do you say? What if it's a workers' compensation? What do you say? What if it's major medical insurance? What do you say? What if it's Medicare? What do you say? What if it's cash? What do you say? See, you have to know that because that's a very different conversation than a re-exam, re-report talking about money on day 13 at the front desk. That's a very different animal. So we should be going through each of those days, each of the days, specifically money, and then specifically time. We'll cover needs separately, but specifically money. How do you handle money in each of those 5 categories, from the patient coming out to day 1 to day 2 to day 4 to the lifestyle care? How is all 5 of those categories handled with money? What do you say to the patient? Make sense?
Mm-hmm.
Okay. These are huge topics, Dylan. You don't learn these, you're in bad trouble. This is what makes need, time, and money is what makes everything go.
I've watched the videos that they
everything,
want to too, and you talking about that stuff, so I've gotten a little bit of learning with that.
yeah, everything else is secondary. You mess up need, you're in trouble.
Mm-hmm.
You mess up money, you're in trouble. You mess up time, you're in trouble. So there's a lot of stuff you got to know to run a practice. You cannot not know those categories.
Correct.
Because you will not even be successful in practice if you don't know those. That's like I just got a phone call yesterday from a guy floundering. He's been out 2 years. He tried to open his practice. It's not going well. So he has to substitute somewhere else to make ends meet. Typical struggle. Doesn't know what the hell he's doing. Now he's even thinking about getting out of chiropractic and becoming a physical therapist. And then he talks about, oh, maybe I need this machine. Going everywhere. That's all, the same dead cycle. I call it the spiral of death.
Thank you.
He doesn't even know what he doesn't know.
Mm-hmm.
And he says to me, yeah, I had a patient call in and I wasn't on their insurance. And he goes, yeah, I just lost a patient the other day because I wasn't on their insurance. I said, what happened? They said they called in and said, hey, do you accept this insurance? And I said, no, but we do, we do plans. And that was it. They hung up and, they didn't want to schedule an appointment. I said, it's because you didn't know any better and you said the wrong thing.
Exactly. We used to do that.
Yeah. That's what everybody does when they don't know.
Right.
Yeah. Happens all the time. I'm like, no, you don't say that.
No.
You just destroyed the relationship and you didn't even know it. See? And guess how many times that's going on in every other scenario? All the other categories of running a practice.
Mm-hmm.
It's like a domino effect. And he's about wore out. I'm like, you're about ready to get out of chiropractic. This is your last go round, buddy. He's already talking about going to physical therapy and doing this. And, that's what happens. You get beat up enough. But most people go, well, maybe I don't know what I don't know. But he couldn't do that. He actually thought he knew everything. It just wasn't working. I'm like, whoa. So what does he do? Totally quits. Gets out of the profession. That's 8 out of 11 chiropractors within 5 years. They don't tell you that in school, do they, Dylan?
No.
So that's where he should be right now. The
Okay.
next place it should be with conviction. I talked significantly
Yes, you did.
yesterday about conviction and how to increase your conviction. First, you got to get a thermometer and go, well, where's he at? Where's he at with time and money recommendations with his present knowledge base? Remember, I told you when doctors came in, I said, okay, let's go to visits and money. I'd go, okay, if your mom, and I personalized it, because if you
Good.
personalize it, they talk like big shit,
Yes.
like they do in college.
Mhm.
So you go, where are you? What's your comfort zone with recommending visits with an average patient? We know patients vary, but we're saying average. An average back pain patient, neck pain patient. What's the average number of visits that you totally feel comfortable with right now? That if somebody told your mom those were the visits, you're like, yeah, you'd have no problems with. See? And then when I go, see, like, let's do this exercise right now, Dylan. Okay. So let's take an average patient, back pain, neck pain. Okay.
Mhm.
And go, okay, what's the average number of visits that you would feel comfortable recommending if your mom was getting that recommendation? How many visits for that problem? What would you say?
We talking for overall for like a year, or are we talking just like right away? Like the first recommendation?
I said everything I'm going to say. I said we're going to take an average patient who comes in with back or neck pain,
Mhm.
and what's your comfort level for the number of visits that you feel comfortable recommending them, that if somebody recommended that to your mom, you'd go, yeah, that sounds right.
15.
Okay. Now, he's already been influenced by seeing you talk more than that.
Mhm.
Well, I watched your video yesterday too, and you were
Okay.
talking 31, 46, 78. So
Right. So you've already been influenced up.
yeah.
Yeah. So most of the time when they come in, it's around 10 or 12. The new guys out of school, usually they're comfortable with 10 or 12. So let's say he says 15. Okay. And then we go, okay, well, how much money? Then I'll go, okay, let's say how much, and she's got to pay out of her pocket. How much money is it okay for the chiropractor to charge her per visit out of pocket? And then I go, okay, are you comfortable with $10? Somebody,
Yeah.
okay. Dylan, what about $12?
Yeah.
What about 15?
Yeah.
What about 18?
Yeah.
22?
Yeah.
25?
Yeah. I would say 30.
Okay, 30. So when I say 35, what happens?
Start getting a little steeper just because I'm
Okay.
thinking about like my mom, obviously.
You see what I'm doing?
Yeah.
I'm finding his real perception of time and money.
True. Yes.
So with him, it's $30. He's okay if his mom gets $30 and they recommend 15 visits. He goes, yeah, that I don't have a problem with that. That sounds right. And then so anything past that, he starts getting uncomfortable. Why?
Good point. Good call.
Why? Low conviction.
Yes. Yeah.
And that's why you have to work on this conviction.
I got you.
That's why just watching a video won't do it.
Right.
That's why just reading a PDF in Wikipedia will not do it.
Okay.
That's why you have to, like what I said, you got to do a case example with him.
Okay.
It's got to be experiential. He's got to see it over time. So that's why we do case analysis. So when a patient comes in, I'll sit back in the room with Dylan. I'll go, okay, Dylan, this was her mechanism of injury. This was her chief complaint. This was her OPPQST. These were her ADLs, and all of them are quantified. And I'll go, okay, here's her findings, all her findings. Then we go, okay, what's our diagnoses? I'm going to ask them. Now we go through all the anatomical categories. Okay, do we have a muscle diagnosis? Do we have a tendon diagnosis? Do we have a ligament diagnosis? Do we have a muscle? Do we have a pain diagnosis? See, we're okay, of all the different tissues, how many of them have been affected by the patient's biomarkers? There's subjective findings, hybrid, and objective findings. How many? See, he won't think that way. He'll just think one or two.
Right.
You got to think about all the anatomy involved, all the subjective findings and all the anatomy involved relative to the biomarkers.
Mm-hmm.
Well, how many diagnoses is that typically? It's usually about 15. It's usually about 15 when you look at it like that, not 3 or 4. Okay, so that's what I'm going to do first. And then, okay, I'm going to go, based on these biomarkers, their age and how long they've had the problem, what stage of healing are they in? Well, they could be in all stages at once, right?
Right.
But right now, where do we have to start?
Inflammation.
We have to start at pain and inflammation. Have you ever had a patient come in where you start at repair phase or remodel phase? No, because they always come in with pain to some degree.
Right. Or they want to be there.
That's right. So you have to start with the pain and inflammation phase, even though they could be in all 3 phases at once. All right. So what are we going to do for their pain and inflammation? What therapies are we going to do? That's what you should be able to explain.
Yeah.
These are the biomarkers. These are the therapies we do. This is how they work.
Mm-hmm.
Are you with me, Dylan?
Yeah.
You see what's happening to conviction?
Mhm.
This is how you drive it home and increase it and get it to where it should be. Because actually where it should be is what? The number of recommended visits should be what that patient needs for all 3 phases of healing.
Exactly.
That's where it should be. Now, money is variable. And then how you get the money up is, and then where we start with asking for money is, remember the first goal is just be successful in getting people to say yes.
Exactly.
Remember how I started with you?
That's right.
We just got to start to get yes to build your confidence.
Exactly.
Forget about the money because you're losing a shitload of money by people leaving.
Mm-hmm.
I said, let's get down in the money to where you're comfortable with the money. And so remember, we've spent a lot of time finding your comfort zone with money, visits, and then we took that and we made sure we spread it out far enough so it was more comfortable for you, not the patient.
That's right. That's right.
Because the doctor's the problem first.
Exactly.
So then we made money a non-issue by having you take it and spread it out over more and more, biweekly payments, more and more, until you go, yeah, I'm okay with the patient paying, 97 or 147 or 197 biweekly, whatever that starting point was. And then that's where we started. Okay, we go, okay, let's start at the lower recommendation in that month. And then that's how you take it up. And then you start getting successful. Over 50% of them are prepaying. Then you go, okay, well, we can increase the price now. And then you just increase it a little bit. Watch the statistics. Long as they stay over 70% over a 4-month, an active life cycle of a patient, 4 months, then you can increase them again. And you only increase it $2 or $3. That's it. No big shift. And you can keep doing that until you hit the tipping point. Until the people saying yes drop under 50%. Now you got to look at your skill. Is it your skill the problem? Or is money the problem? That's what you got to look at. So with him, we would go, okay, what biomarkers are we going to use for the patient? Then we go, okay, what therapeutic protocol? That's how you drive home the therapeutic protocol with him. And we're not going to second guess it day to day.
Right.
They stay on that treatment schedule to the first re-exam.
Exactly.
There's going to be fluctuations day to day.
Mm-hmm.
The main thing we're looking for is a decrease in intensity and frequency over that time. That tells us it's working. What we're doing is working. But I'm not going to change their connective tissue from day to day. Now, neurologically, you can. You can give an adjustment and immediately somebody feel better immediately neurologically. So if you're only going to base your care on neurological and nothing on connective tissue, then yeah, it could just be a few handful of visits.
Mhm.
And then they heal wrong the rest of their life.
Right.
See?
Mhm.
So then you go, okay, let's do the re-exam. Do the re-exam. This is how you do case analysis and drive it home. Do the re-exam. Okay, let's look at the results of the re-exam. Let's compare them to the initial results. Go through each category. Is it better, worse, or the same? Better, worse, or the same? Let's say it's all in getting better. It's decreasing in intensity and frequency, so you know everything's working. And then you go, okay, are they heading into the repair phase? Are we okay to start maybe some repair phase? You go, okay, well, what's the therapeutic goal of the repair phase? What's to increase all three ranges of motion: active, passive, and joint motion. So, okay, so do we still need to do other therapies? In other words, do they still have these other biomarkers where they still need those continued therapies, whether it's for pain, muscle spasms? Do they still need those at all based on the biomarkers? A lot of times they do. So that may continue and we may add in, or maybe they'll drop off one of the therapeutics because of they're doing better.
Mhm.
And then we'll go ahead and add in the next therapy for the repair phase. How does it work? Why does it work? And should we have that quantified? The three ranges of motion? Active
Mhm.
range of motion? Yes. Passive range of motion over pressure? Yes. Joint motion? Yes. Motor unit motion? Yes. With tenderness? Yes. Should we have all those biomarkers? In other words, you're substantiating the need for care for what you're doing, right? Does this make sense, Dylan?
Yeah.
They didn't teach you this in school, did they?
No.
Yeah. This is what care is based on.
Mhm.
Okay, so then you go, okay, we're going to add this. They still need these therapies for pain or muscle or whatever. Then you go, we're going to start adding this because now we're starting to feel better with intensity and frequency. Typically, I'll add like reciprocal inhibition or something like that, or if you add intersegmental traction or whatever. Okay, so now we're starting to pay not just attention to their initial biomarkers, but now the ranges of motion and active, passive, and joint motion. They stay that way until the next re-exam.
Mhm.
What am I looking for? Improvement with intensity and frequency. That's what I'm not looking for yes or no. I'm looking for an improvement. Is it decrease in frequency and decrease in intensity? That's all I keep looking for. If I keep getting that, I'm in the right direction. We do the next re-exam, then the same thing happens. We're going to compare it to the previous exam and go, okay, what biomarkers are present? Do we still need to be doing pain? Are they still having pain? Well, if they are, we still need to do something for pain.
Yeah,
Do
right.
they still have tenderness? If they are, you still need to do something for tenderness. Do they still have muscle spasms or tension? Then you still need to be doing that. Are all their ranges of motion back to normal? If not, you still need to be doing something for that. You see?
Mhm.
And you can't really start rehabilitation, remodeling, until they at least can go through the full range of motion pain-free. Because what happens when they can't go through the full range of motion and you start applying therapies then, because remember, what's the therapeutic goal for the remodel phase? It's to increase strength and elasticity.
Hmm.
We started working on the elasticity with PNF also, but now that's where we're going to pay a lot of attention, because what does that do? What does the strength do? That decreases the likelihood of it being a permanent problem to some degree, and it decreases re-exacerbations. It increases the alignment of the collagen and makes it stronger. That's what the therabands do, or any resistance. And it's only resistance. It's not exercise. You're just trying to stimulate a neurological response. That's just easy resistance. It's not force. Same like PNF. When you do PNF, it's not force. You go, okay, hold, just push a little resistance. Okay, hold. It's not, no. We're just trying to fire them up, fire the neurology. That's all. Same with connective tissue, collagen, type 3 collagen. We're just trying to stimulate it. So when you go through the motion, There's a neurological response called the piezoelectric effect. It's not about lifting weights. It's not what it's about. Okay. So they go through that series until they plateau. You just have them resistance, take them up, until they plateau in 2 re-exams. They either get 100%, so they stay that way and they keep going up. If they keep going up, you keep doing it, right?
Right.
Okay. Or they plateau. Either it goes away, so they're fine. They keep improving. You keep doing it. You can decrease the frequency or, as they keep improving. And then you hit a plateau where you get 2 re-exams within the remodel phase, it's over.
Mhm.
They're at MMI. It's now permanent. It is what it is. Now they go into palliative care. We're not affecting that tissue. Now they just get periodic palliative care. Palliative care is a symptom care. What's the most common palliative care for a chiropractic patient? It's usually a chiropractic joint because of joint dysfunction. They all have abnormal biomechanics and joint dysfunction. They typically have some tenderness, fixations, and they typically have and pain associated with it to some degree, and a reflex muscle spasm to some degree. That's typically the fixation complex. And then of course, if it's let go, it gets worse and worse over time. Starts to get more painful, more tender, and then people start limiting their activities. They start taking drugs, or if it's a chiropractic patient, they go, I need to get an adjustment. That's palliative care. And then typically I'll also maybe include some anti-inflammatory supplements so there's no side effects. That's the palliative care that's the 3 phases of the healing. And then of course the last piece of the puzzle is lifestyle patient education. Well, that's not maintenance care.
Right.
Lifestyle it still has to do with the 3 phases of healing, but now we're focusing on inflammation, visceral inflammation, somatovisceral inflammation, neuromusculoskeletal inflammation, because that's the precursor to 95% of morbidity. Now that's a whole nother animal. And it's educated in, there's specific therapeutics, it's targeted, it's measured. It is not maintenance care. Okay. Palliative care is just maintenance care. Somebody just needs to get an adjustment every now. That's maintenance care. And you never want to do maintenance care. Why? You've never heard that before, have you, Dylan? You need to stop hanging around losers. Why do you never recommend maintenance care? Because 95% and 97% of the people do not get maintenance care. You're already in a losing proposition.
Yeah.
Do you want to play a game where you lose 97% of the time? Hell no.
That doesn't sound very fun.
What?
That doesn't sound very fun.
I want nothing to do with that bullshit. So I'm not doing maintenance care. I'm doing lifestyle care. Okay, that's a whole nother animal. But that's how you need to take him through these patients.
Okay.
And then he'll see it. He'll see the beginning, he'll see the re-exam, do the motion studies, the follow-up motion studies with the biomechanics. You'll start seeing the differences in the motor unit movement. That's what increases conviction. And I found it takes anywhere from 3 to 6 months. You got to do that you got to do case evaluations like that for about 3 to 6 months. In other words, he's got to see a full cycle of a patient, not just one.
Exactly.
Multiple. He's got to see the full cycle of from the time they come in, going through all 3 phases of healing until they're at MMI, before he goes, I see. I got the picture with visits relative to physiology and biomarkers. And then he has to know what are the biomarkers that are going to clear up first? Symptoms. Intensity and frequency is going to clear up first. Neutral range of motion is going to clear up first. The last range of motion is going to be the plane of motion at the end. That's the very last symptom care. Well, if you never evaluate it, you never check it, you're not even going to know.
Mhm.
Tenderness will start to clear up in active range of motion. It doesn't clear up as fast in overpressure. Well, if you don't even test it in overpressure, you won't even know. Typically, we don't have neurological problems, reflexes, dermatomes, cranial nerves. Those aren't typical chiropractic problems. Or what's the orthopedic test that'll clear up first? A single plane of motion.
Right.
What'll clear up later? Two planes of motion in overpressure. What's the very last orthopedic test that'll clear up? Three planes of motion in overpressure. You got to know that. You just do one test and it's in one plane of motion and it's normal and you don't know any better. You think they're normal because you didn't even do the right test.
Mhm.
Same with x-rays, looking at the x-rays. Do we have normal motion or abnormal motion? That matters. And then you go to muscle strength, same thing. It wasn't done ergonomically correct. Did you do it now that's actually when you do apply force. When you test muscle strength, that's not resistance, that's force. It's usually not done right. It's usually it's done too weak because the doctor's afraid to hurt the patient.
Mhm.
So you should be able to unload full force in all planes of motion and it be 100% normal. That's what you should be able to do. That's what normal is. Not being ginger. You're testing the damn muscle strength.
Mhm.
That's when you do apply force. It's not just resistance. That's the mistake that's usually done with muscle. And then you looked at the ranges of motion. Active range of motion typically clears up first, except the last plane of the injury, and then at the very end. And that can be totally normal, but abnormal overpressure range. That's the last range of motion typically to clear up. And a lot of times it doesn't, especially with injuries, especially in the plane of the injury. And then you look at joint motion. What's the absolute last thing to clear up on a patient? Joint motion. How's that measured? Motion x-rays. You don't know that. How much can you get wrong if you don't even know what I just said, Dylan?
A lot.
You can do the test wrong, be weak at the test, and the patient has all these positive findings, but you didn't find them because you didn't do the test right.
Exactly.
That's how you increase conviction. Do that for several patients over the life cycle of a patient. There you go. And I found it takes about 3 to 6 months, usually about 3 months for the doctor's like, yeah, we need to get this patient all the visits. Let's just make the money work. Let's just, whatever it costs, 1,000, 2,000, that doesn't matter. What matters
Yes.
is what they can pay. What matters is the terms, not the amount.
Mhm.
Just make it affordable. And that's easy to do. Just drag it out, whatever, 3 months, 6 months, 8 months, 9 months, whatever, into biweekly payments to make it affordable. People can afford $3,000. They can't afford it up front.
Mhm.
But you can damn well spread it out to where it's $147 biweekly or whatever. And they're like, yeah, no, it's no problem.
Mhm.
That's how it works. That's how we make it affordable for everybody.
Mhm.
So we're going to give them the therapy. We're going to give them the visits. We're going to make sure they get through all 3 phases healing. I don't care what it costs. It's going to be a big number. And 8 out of 10 of them won't be able to afford that $3,000. But they will be able to afford terms.
Mhm.
They'll be able to afford $147 biweekly. And the patient gets everything they need. And you're just treating and monitoring and quantifying all the way through. That's quality care. And then can you communicate it effectively? How well can you communicate that? Well, if you don't even know it, you won't even be able to communicate. Or when you do communicate it, are you communicating it from memory? Or are you communicating it from conviction? Well, where am I communicating it with you right now?
Conviction.
Conviction. It's coming from my heart, my gut. That's conviction. And that's what the patient needs to feel, not a damn can line.
Exactly.
Make sense, Dylan?
Yeah.
That's where he's at right now. He's got to go. Now you need to go into patient education, 3 phases healing, and you got to go into the case analysis.